Hi, and welcome to this week's Neuroanesthesia rounds. My name is Eric King. I'm one of the PGY2 residents. And this week I was asked to go over the anesthetic considerations for Meningomyelocele, Ecephalocele, DandyWalker Complex, and Chiari Malformations. So just some background information first. So essentially neural tube defects are congenital anomalies of neurodevelopment. They can affect the cranium or the spine. Just after heart defects, they're the second most common congenital disability, and they're associated with folic acid deficiency in certain medications, which are typically folic acid antagonists. There's different types. So cranial defects, one we'll talk about would be the Ecephalocele, and then you have open and closed spinal dysraphisms. Specifically, I'll talk about the Meningomyelocele, which is the most common type. Essentially, a closed neural tube defect is defined by a defect that's covered by skin and neural tissue is not exposed, whereas open neural tube defects, the defect is covered by membrane or sometimes nothing at all. And the open neural tube defects comprise 80%. So spina bifida refers to failure development of the spine to properly enclose the neural elements within the bony canal, and it results from abnormal fusion of one or more vertebral posterior arches. Spina bifida occulta is a closed spinal dysraphism. The cleft is usually covered by skin and does not involve any neural structures. The skin may show an abnormal dimple, hair patch, it can have a dermal sinus tract, hemangiomas or lipomas underneath. The open spinal dysraphisms include a meningocele. This is where just the meninges are herniating through the spinal cleft and it creates a CSF-filled sac, but there's no neural tissue within that sac. And then the difference between that and the meningomyelocele would be that the spinal cord and meninges are both herniating through, and the defect lacks skin and sometimes even a dural covering. So we'll talk specifically about meningomyeloceles. They're the most common type of neural tube defect, and these patients have varying degrees of motor and sensory deficits, and that depends on sort of the level of the defect. Where higher up, you have more deficits typically. Most of these patients will have bowel and bladder dysfunction for the rest of their lives, and these defects or deficits are typically irreversible if they're present. There are a number of associated conditions, specifically a Chiari malformation in about 90% of these patients. So whenever you see a meningomyelocele, you must always consider other anomalies that may be present, and a Chiari malformation should be highest on the list. These patients may also have tethered cords. They can be associated with hydrocephalus, brainstem abnormalities, cardiac, esophageal, renal, and orthopedic anomalies as well. These is just a graphic depicting that. So specifically for anesthetic considerations for us, when a meningomyelocele is present, surgical closure is usually performed within 24 to 48 hours after birth. Some centers actually offer prenatal repair, but these have specific exclusion criteria and only offered in certain locations. Studies show that they may have improved neural outcomes, however. This is weighed beside the risk of preterm birth and maternal morbidity as well. For your preoperative assessment, always have to assess for and also consider that these patients are high risk for having or developing latex allergy at some point in their lifetime, just because they are frequent hospitalizations and procedures. So latex-free environment is recommended. With any of these conditions, you should review any neuroimaging that's available to appreciate the size, location, whether there's any brain involvement, and make notes of these neurodeficits preoperatively. And then again, identify the congenital anomalies that may be also present, which we talked about before. Intraoperatively, these patients may pose to be a difficult airway, specifically because of positioning. There should be special care not to compress or damage the defect, and depending on the size, you may have to have different strategies on how to intubate these patients. Options may include having the patient lie supine with either supports, like rolls, or gel donuts with the deficit within the gel donut, or you may have to intubate in the lateral decubitus position. Again, since also these patients have Chiari malformations associated with this condition, you should be careful with neck extension due to cervical cord compression. So all these factors added together may make airway potentially difficult. These patients also have abnormal ventilatory responses to hypoxia and hypercarbia, and they may also have, if they have brainstem involvement, may have issues with swallowing, vocal cord paresis, which can lead to stridor. They also are prone to apneic episodes, which should be both for intra-op if you're doing a volatile induction, or post-operatively, as these patients should be monitored. If there are deficits that are present, these patients may be sensitive to succinylcholine and can have a hyperkalemic response. And so you should be careful when using this medication. And then obviously your prone considerations need to be taken into account, as this procedure will need to be done prone. So avoiding compression injuries, nerve stretch, IVC compression, etc. These procedures are typically done with neuromonitoring, and so that comes with requirement for TIVA and minimizing your signal interference, and reducing the amount of long-acting neuromuscular blockade that you use. Significantly, these procedures have potential for large blood loss and third space fluid loss, and that the larger the deficit, the larger the risk. And often the actual amount of third space loss is often underestimated, and so a fluid strategy should be thought about with adequate IV access and monitors. Again, with exposure of the meninges, you have possible for significant heat loss. And again, because of brainstem involvement, these patients can have autonomic instability. They're also at risk for autonomic hyperreflexia if the lesion is at level T5 or 6 or higher. And as I mentioned before, apneas and respiratory insufficiency post-operatively is a potential. And so monitoring in the ICU is recommended. Moving on to encephalocele. So encephaloceles are extracranial herniations of brain and or meninges through a defect in the skull. There could be primary or secondary. Secondary refers to trauma or post-surgical. We'll focus more on primary encephaloceles. Occipital encephaloceles are more frequent at about 85%, but they can herniate in other directions. And this picture shows a frontal encephalocele. Southeast Asian population is the most common population where this occurs, and they specifically have higher rates of frontal encephaloceles. So the herniated tissue, it may be normal brain, but it also may be fibrous atrophic gliotic tissue with little or no function. And the clinical features really depend on this, and as well as the location and the severity of the deficit. With frontal ethmoidal encephaloceles, they can be occult if they're small, or they can have severe craniofacial abnormalities. It can herniate. There could be basal herniation, which may or may not be apparent. They may have broad nasal bridge, ocular hypertelorism, so spacing out of the eyes, as well as nasal or pharyngeal masses, which can have airway obstruction, difficulty breathing. They may have recurrent upper respiratory tract infections, and these basal encephaloceles are higher risk for meningitis and CSF leaks. Lastly, occipital, usually most obvious and seen on prenatal ultrasound. These tissues usually is covered by skin, and they may have cranial nerve deficits if it's large. They may have poor feeding, spasticity, blindness, seizures, developmental delay, and occipital encephaloceles are specifically associated with Chiari malformation, which we'll talk about later. Again, they're frequently present with additional anomalies. with varying degrees of sensory motor deficits depending on the type of encephalocele. These patients can have hydrocephalus, corpus callosum abnormalities, and cerebral dysgenesis, as well as cardiac anomalies. So again, reviewing the history, reviewing the other tests to make sure you're not missing on the other associated conditions. Surgical treatment is appropriate unless the patient is not deemed to recover from surgery in a meaningful way, or if other lethal anomalies are present. Basal encephaloceles, or those with CSF leaks, require more prompt surgical repair due to the infection risk, and frontal and occipital encephaloceles are typically treated electively but are preferred to be done early in infancy. If hydrocephalus is present, then they can place a VP shunt usually prior to the procedure. Our anesthetic considerations, again, lots of these considerations will overlap between all these conditions that we're talking about today. Again, review neuroimaging, make note of any neurodeficits, and if there's elevated ICP. Make note of any associated anomalies. And again, these patients are high risk for latex allergies. The most significant consideration for these patients would be difficulty with bag mask ventilation and intubation. You can imagine this patient coming to your operating room. You may have difficulty with positioning. You won't be able to adequately extend the neck. These patients may, if it's a basal encephalocele, may have airway obstruction after you induce, and you should have care not to rupture the actual deficit. Intubation strategies may include I suppose it depends on the location and the size of the actual deficit. You can do IV inhalation induction in a lateral position if it's easiest, and then reposition for intubation. If the deficit is small, you may be able to get away with putting the deficit within a gel donut and lying supine. If it's large, you may need extra assistance to support the deficit with potentially the head even off the bed or in the lateral position. If you see a patient where you feel like it may be very difficult to actually intubate this patient, you always consider flexible bronch. Intraoperatively, again, they may have abnormal ventilatory responses to hypoxia and hypercarbia. We talked about positioning considerations and how you should have care to prevent sac rupture. And again, these patients have potential for blood loss and third space fluid loss. Obviously, higher risk with larger deficits. Again, postoperative apnea is respiratory insufficiency, and proper monitoring postoperatively in the ICU is recommended. Nasal frontal encephaloceles typically do quite well, and they can have normal to near normal intelligence, whereas occipital encephaloceles typically are associated with other anomalies, and their outcomes really depend on whether it's associated, what the associated anomalies are, and the severity of the deficit. Moving on to the DandyWalker Complex. So DandyWalker Complex is defined by a hypoplasia of the cerebellar vermis, and this leads to cystic dilation of the fourth ventricle and ultimately leads to hydrocephalus. The cerebellar hemispheres, because of this, are flattened, and the corpus callosum may even be absent. The manifestations of DandyWalker Complex usually appear within the first year of life, and it presents with obstructive hydrocephalus with dilation of the third and fourth ventricles. And this shows in about 70–90%. So they present with elevated ICP, bulging anterior fontanelles, and macrocephaly. It should be noted that this is a heterogeneous disorder, and so the presentation of these patients may vary greatly depending on associated conditions. So it can present from chromosomal abnormalities, it can present from environmental exposures, or it could just be a sporadic defect. There's a syndromic form of a DandyWalker complex that's associated with craniofacial, renal, or GU, cardiac, GI, limb, and vertebral pathologies. I've highlighted cardiac because this is the most commonly associated, is the most common extracranial abnormality, which can present with ASD, VSD, patent ductus arteriosus, or other valvulopathies. Specifically for the craniofacial abnormalities, they can have a cleft palate, micrognathia, and macroglossia, which we'll talk about may make intubation difficult. Because it's of the brainstem involvement, it can interfere with the respiratory control center, leading to irregular respirations, and they often have developmental delay and cerebellar ataxia. So moving on to our anesthetic considerations, most of these patients will require a VP shunt if they have elevated ICP. If this patient's coming to the operating room, again, identify any additional malformations that are present, as we talked about. If they're coming for a VP shunt, they most likely will have elevated ICP, and that brings in your typical ICP goals. This is often in conflict with the difficult airway that we talked about previously. These patients have cleft palate, micrognathia, macrocephaly, and macroglossia. An awake intubation may be required despite an elevated ICP. Once again, these patients, most of them will require ICU monitoring post-op due to the altered respiratory control due to brainstem involvement. They're higher risk for seizures as well post-operatively. Lastly, we'll talk about Chiari malformations. Chiari malformations are a group of disorders defined by anomalies of the cerebellum, brainstem, and craniocervical junction, and it has downward displacement of the cerebellum plus or minus the lower medulla into the actual spinal canal. So you have essentially, if you have herniation of brain tissue into the spinal canal. There are different types, 3 types in total. Type 4 and 5, I believe, were initially thought to be part of Chiari malformations, but they have since been determined to be a part of a different syndrome altogether, and so they have been removed. Type 1, you have abnormally shaped cerebellar tonsils, which are displaced below level of the foramen magnum. Type 2, or called an Arnold-Chiari malformation, has downward displacement of both the cerebellar vermis and the tonsils, and it leads to a brainstem malformation with sort of a beaked appearing midbrain. And type 2 Chiari malformations are highly associated with spinal myelomeningocele, as we talked about previously. Finally, type 3 is the most rare type, but it's a small posterior fossa with a high cervical or occipital encephalocele. And this usually has displaced cerebellar structures into the actual encephalocele. This is just a picture depicting sort of the herniation of the cerebellar tissue into the spinal canal here. In terms of symptoms, type 1, they are typically asymptomatic until adolescence or even into adulthood, and it's typically a slow, insidious onset. Symptoms start forming once there's compression of dural or neural structures, or from development of syringomyelia, which is a fluid-filled cyst within the spinal cord. Typically, these patients will just present with a headache. They may also have cerebellar findings, including nystagmus and ataxia. If they have brainstem compression, you can have hoarseness, focal cord paralysis or stridor, palate weakness, recurrent aspirations, and often they have central and or obstructive sleep apnea. 10% of these patients present with hydrocephalus, and they can also present with myelopathies with motor sensory changes, autonomic dysfunction, and syringomyelia and scoliosis in about 35%, which can lead to neurologic deficits. Quadriparesis with hypotonia is possible. For type 2, they're almost always associated with lumbosacral or thoracic myelomeningocele. Typically, they're seen on prenatal ultrasound or at birth. They have lower brainstem and cranial nerve dysfunction, which can lead to dysphagia, weakness, stridor, apnea, and aspirations. And they typically have progressive hydrocephalus in infancy. Again, associated with syringomyelia, scoliosis, tailored spinal cord syndrome. And again, whenever you see a Chiari 2 malformation, always think myelomeningocele as well. Finally, Chiari Malformation 3, associated with a high cervical or occipital encephalocele, as we talked about before, and they have a high mortality rate due to respiratory failure, severe neuro issues, epilepsy, and neurodeficits. Our anesthetic considerations for Chiari Malformation. Typically, surgery is required to decompress the craniocervical junction and restore normal flow around the foramen magnum. Preoperatively, lots of these will overlap with what we've already talked about. Review neuroimaging. We're going to discuss with the surgeon what the actual procedure is planned, whether dural opening is planned, and whether intraoperative neuromonitoring is required. Identify your associated comorbidities. Specifically, we want to think about brainstem dysfunction, stridor, apnea, recurrent aspirations, autonomic instability, as well as seizures. As a reminder, Chiari 2, myelomeningocele, Chiari 3, occipital encephalocele. And they're, again, high risk for latex allergy. Intraoperatively, we have our increased ICP goals. They're at higher risk for herniation, and so that should be definitely a consideration. They may have an unstable C-spine and with limited C-spine range of motion and C1-2 instability, as the dens may impinge on the actual brainstem itself. Care should be done with bag mask ventilation, and a flexible bronch should always be considered just to avoid any sort of neck manipulation. If there's brainstem involvement, they have abnormal ventilatory response, as well as swallowing, vocal cord paresis, stridor, apneic episodes. Again, potential for significant blood loss, autonomic instability. These patients can have quite labile blood pressures. They can have arrhythmias, bradycardias. If there's decompression is planned, it's typically done in the prone position. If these patients have neurodeficits, they may be sensitive to our neuromuscular blocking agents, as if it makes weakness even worse, especially if there's a syringomyelia present. And typically, we want to avoid succinylcholine in these patients, as they may have a hyperkalemic response if there's deficits. These patients require post-op ICU for close observation due to the apneas and respiratory insufficiencies, and possible brainstem compression. Careful planning for extubation, full reversal, breathing spontaneously and awake, avoiding oversedation. And that is the end of the presentation. Thank you for your attention. These are my references.